This is going to be the fourth video on chapter 18. This is newborn physical examinations.
Okay, so for the newborn physical exam or the physical assessment, these are the few things that we're going to start or that we need to know. So prenatal history is really important. We want to know mom's history. It's going to help us identify if there's any high risks or complications or potential complications in the baby. For our physical examination, we're going to do anthropometric. That's basically just human body proportion. So we're going to do body proportion measurements, meaning we're going to do the length and the weight. We're going to do head circumference and chest circumference. And most of the time, you're going to see abdominal circumference also done in the hospitals. These are measured in centimeters. It's crucial, it's really important to get an accurate baseline measurement to track and monitor if the baby is growing adequately, because we plot those on a growth chart all through, until they're 18, right? So we plot that growth chart to make sure that the baby is growing appropriately. And then it's also that initial one. So if my head's too small or too, large, that can be indicated of different developmental disorders. So a normal head circumference will be 32 to 36.8 centimeters. Remember that cervix dilates to a 10 centimeters, so we still have a significant amount of stretching that happens as that baby's head's delivered. The head should be 2 to 3 centimeters larger than the chest circumference. If it's more than that, if it's 4 centimeters larger or bigger, we could have a problem with hydrocephalus, which is a fluid accumulation in the head and the brain. If it's less than 32 centimeters, that would indicate microcephaly, which could have some kind of chromosomal or developmental disorder. A normal chest circumference would be about 30 to 33 centimeters. And then the length of the baby, normal findings would be 18 to 22 centimeters. Weight, the normal findings would be 2,500 to 4,000 grams, and that's about 5.5 pounds to 8.8 pounds. We do expect a weight loss of about 5 to 10%. That first week after birth. We also expect that the infant will regain that weight around 10 to 14 days after birth. Most newborns will gain about 110 to 200 grams per week. We are going to do vital signs. We kind of went over those and what's expected. Baby's vital signs are monitored every 15 minutes for that first hour, and we really just want to make sure we're getting that temperature back up to 97.7 and maintaining that temperature. Skin, we're going to go over skin conditions that are normal findings, and there's a figure in your book too that kind of shows all the skin conditions. And then head, so it's important that we talked about the size of the head. We also want to assess the fontanelles, that they're open, that they're not, that fontanelle's not bulging or sunken, that their sutures are approximated. Do they have caput or molding? We'll talk about that, because that molding is like how it shapes itself to come out of mom's pelvis. So then we're also going to assess the face, the nose, mouth, eyes, and ears. We're going to make sure that they're symmetrical. We're going to look at the nose for size, symmetry, and lesions. The eyes should be in line with the ears should be in line with the outer canthus of the eye. We're going to make sure the mouth is, that the patient has a suck reflex, that the palate is intact, and not cleft. On our neck and chest, we're going to inspect the newborn's neck for movement and their ability to support their head, which usually most infants can't support their head because their head's so large, and their neck, they don't have a lot of muscle control in that yet. But we should be able to at least move the neck freely in all directions. As for chest, we should inspect the size, shape, and symmetry of the newborn chest. And again, it should be about 2 to 3 centimeters smaller than the head circumference. We kind of talked about genitalia already. We expect that it will probably be engorged, boy and girl genitalia. But we expect that in the boy, that the testes will be descended, that we'll be able to palpate those. We do want to check for the urinary meatus. Sometimes this can be hard to find, but we'll move that foreskin a little bit and see if we can see that urinary meatus. In the girls, we'll expect to see engorged. They might have some kind of leukorrhea or some kind of vaginal discharge, which would be normal just due to mom's hormones and getting rid of extra estrogen and progesterone. For the back and upper extremities, we're just going to be looking for movement. We're going to make sure that the spine is in line and there's no openings, that the skin's closed and intact. The neurological status, we talked about that a little bit, but their alertness, their ability to make eye contact, their muscle tone, and their reflexes, this all indicates a healthy neurological status in the newborn. And we'll go over those reflexes here coming up. So this is the ABCs of physical assessment, things that you need to do. You need to listen to the lung sounds, abdomen, and heart. So we want to perform procedures that keep them quiet first. So if my baby is calmly laying there and not crying, then I'm going to auscultate right away, just so I can listen to that, get a good assessment without them crying. We might do blood tests. This isn't routine, but if we're going to do a blood test, we can do that after we do the assessment because that's going to make them cry. And then we'll test reflexes, which can also make them cry. We're going to measure the chest, head, and length of the baby. We're going to determine and monitor vital signs every 15 minutes for an hour until the newborn's temperature stabilizes. We're going to do an axillary temperature. We're not going to do oral or rectal. We're going to do axillary temperature. And then we'll just follow protocols for glucose checks, for hypoglycemia, if mom has diabetes or the newborn has a complication. So this is the figure from your book. This Vernex, that's that white cream cheese kind of substance that is common. I don't think there's a picture of it, but it's common. It just protects the skin from all the fluid. The more preterm the baby is, the more Vernex they have, and then the more post-term or date term the baby is, the less Vernex they have. Stork bites, you can see here that's kind of this underneath the neck. They also typically will have it here between the eyes or on the nose, on the forehead. So they typically will appear on the face or the back of the head. And when they cry, they become even more red in color. They're harmless. There's really no treatment for them, but most of them will go away within a few months to a year. The next one up is Malia. And these are the teeny white bumps. Some people call it baby acne on the baby's face. It's caused from skin flakes that become trapped. And then when they become unopened, the sebaceous glands form around it. So this can form at any age. It's really common in newborns. Maybe not when they first come out, but within the first couple weeks, a lot of the babies will get these little, we call it baby acne. But they usually just kind of resolve on their own. And typically nothing needs to be done about it. Mongolian spots, these are really common. This will be that kind of bruising that you see here. It's not bruising, it's just a darkening area. It looks like a bruise, but it's not. So it's typically on the spine or the buttocks or the back. They're benign. It's common more in ethnic babies. They're just caused by hyperpigmentation. And then they usually go away again within a few months, if not the first year. They'll start to go away. Erythema toxicum. This is what's called a newborn rash. It usually appears the first few days after birth, and it's super common. So it's benign, and it will typically go away and fade. I notice that in the heat, it will come up a lot more, like with our summer babies. Harlequin sign, this color change appears approximately like 10% of newborns. It's distinctive. It's because it's well demarcated color change, and typically in a large spot. Sometimes it's half their body. We'll have this erythema. It's also benign, and the color will fade as the time goes on. This nevus flammiosus, that's this one here too. So sometimes we'll call this port wine stain. It's benign. It is a cosmetic concern because it doesn't typically go away. It got its name because it kind of looks like wine, like got spilled on the baby. It can get darker, so it's more of a cosmetic thing that laser treatments can kind of help take care of, make it less noticeable if families want to go that way. And then this is a strawberry hemangioma, or a nevus speculosus. It's overgrowth of capillaries. It's most commonly seen after birth. Sometimes it will appear the first few weeks after birth. About 80% of hemangiomas stop growing by about 5 months. They stay unchanged for several months, then they slowly begin to disappear over time. So typically around 10 years of age, the hemangioma will be gone. And then this is just, I don't know if it helps you more, but there's just a different explanation of it. But these are just kind of common ones. Mongolian spot, super, super, super common. Milia, that's very common. Raised rash. That erythema toxicum is also that red rash, a newborn rash. So this is more like white. Think of like white, like an acne, but not like pus filled, just like white little flaky spots on the skin. And this is more of a red rash. And those are super common. Port wine stains aren't quite as common. And then the stork bites are typically common. These are more common on your like really white babies, your really pale babies, and the Mongolian spots will be more common on your like darker skinned babies. So the head, you're going to see a lot of different kind of shapes and sizes of heads. Molding is what this picture is. You can see how it's kind of a little bit elongated. And this just helps the head accommodate for the passage through the birth canal. So remember how we have that open suture line, and the cranial plates can kind of squeeze on top of each other to facilitate that baby coming out of the birth canal. So you see these babies kind of come out with a little bit of a cone head at delivery. This can be shocking to a lot of parents, especially if it's their first baby. They want to know if it's going to stay like that, and if everything is okay. So we just assure them this is normal, and that typically the molding will go away within the first 24 hours. You put a hat on and no one really notices. And if the mom was in that second stage of labor for a long time, then that molding is going to be more. Like the longer that baby's head was in that birth canal, or we were pushing for a long time, then that baby is probably going to have more of a cone head than if it was a quick delivery. Or like our C-section babies, they don't have nearly as much molding as the vaginal babies do. Let's talk about here, I think there's a picture here, yeah. So let's talk about caput and cephalohematoma. So caput is kind of that cone head also. And again, if we have that prolonged labor, so molding will be kind of your normal overriding elongation. Caput gets to be when it's a little bit more severe, and it crosses the suture line. So that's going to be your most important identifying feature, is you're going to see a swelling on the head, like a soft area, like soft palpation, but it's going to cross the suture line. It's not going to just be on one side of the head. Whereas a cephalohematoma, this is localized, a collection of blood right underneath like this cranial bone, right? So it's confined to one bone. This would be more of it doesn't cross the suture line, and it's just an effusion of blood. It's like a hematoma, right? So beneath the periosteum of the skull. So this would be more of a danger sign, right? This would be like a brain, like a brain bleed, like a hematoma in there, where this is just kind of the extra fluids around the brain. So there's this one, there's some pictures, but caput crosses the suture line. So CS, caput will cross the suture line there and kind of go right over. This is a relatively normal finding, usually more pronounced if we've had a traumatic birth, a long second stage of labor with lots of pushing, or like a vacuum assisted birth. Cephalohematoma, this is trouble. So we don't really like this. This will be, we'll talk about this probably again, but a vacuum assisted birth with multiple pop-offs, they're going to be at more of an increased risk for cephalohematoma. So we only allow 3 pop-offs and we're pulling with that vacuum, because after 3 pop-offs, the risk for the cephalohematoma will go up dramatically. And then the other abnormalities that we've kind of talked about would be the small head. This could be signs of chromosomal problems, or and then macrocephaly is a large head. This could be signs of hydrocephalus. And then our fontanelles, we're going to pay attention to those to make sure that they're not too large or too small, or they're closed. Those would be all dangerous signs for the baby. I also want to go into the newborn reflexes here. So these are just kind of a neuro assessment to make sure our baby's neurologically intact. Blinking is a reflex. Moral reflex, that's this one over here. That's that startle reflex that we assess for. It will typically go away even before 3 to 6 months, but it can last that long. The grasp reflex is down here. Stepping is if we hold the baby up and they kind of do a little bit of stepping. Tonic neck reflex is when you turn the baby's head and it kind of, the other arm will straighten out. We call it like the fencing reflex. Sneeze is a reflex that they're born with. Sneezing is normal in a baby, and it's typically just reflexes. A lot of times if the baby's sneezing, the parents will think that they're sick or have allergies, and we just want to remind them this is a normal reflex in babies. Rooting reflex, this is when, right here, you rub their finger along their cheek and they will kind of move toward that finger. This is what helps them latch on and breastfeed. Gag reflex, cough reflex, and Babinski. Did we have suck on here? Did I miss that? But suck reflex is also an important one. And then we do the plantar grasp here, and that's where their toes grasp over their finger. It's nice and cute. I thought this picture was just a little more simple to look at, but Babinski, a positive would be a flaring of the toes, a negative would be bringing them in. Moro is that startle reflex, which I'll show you how we elicit it. We don't really, you can do this like controlled drop, but I'll show you how we do it.
Oh my God, my dog
Rooting,
is so
this is helps
annoying.
them find the nipple. Sucking, making sure that they can eat. The tonic neck reflex is that those arms will straighten out to where their head is turned, and then the palmar grasps. So these are typically the ones that we assess for in the hospital and during your newborn assessment.
Are we almost done? Yeah. Jeez, Thor is like freaking out.